Without any further delay, let us extend a warm welcome to Dr. Means.
Thank you. It's a privilege to be here with you. These are my disclosures. The only one that may possibly be relevant to the topic initially is that my daughter is employed by Tempus AI, which is one of many medical genomics company, and some of the evaluation of pure red cell aplasia in the current era does involve medical genomics. The off-label use question is always a tricky one because pure red cell aplasia is basically an orphan disease, and so nothing is approved for it specifically, but everything is approved for something in the immunosuppression, immunomodulation area. The most stringent disclosure I'm required to make is that since I'm the chairman of the ABIM Hematology Exam Approval Committee that does the certification exam and the traditional every 10-year MOC exam, I am required to state anytime I give a talk to anybody on anything that the talk does not derive from the deliberations of that committee. So if you get any answers that help you on the board, it is only an amazing coincidence. Possibly my most important disclosure is that the picture on the preceding page is really terrible because it was done during the pandemic when the school practice plan decided to change the lab coats, and we were all required to have our picture taken in the new lab coat with the new logo, and the only one, the biggest one they had was 2 sizes too small for me. So in the picture, I am not only holding my breath just below the picture, I am trying to hold the coat closed. So that accounts for the fact that I look like I'm choking to death, because I was.
Thank you, Dr. Means. I will go over the first case. This is a 66-year-old Caucasian male patient. Brief history: in 2014, he presented with the hemoglobin of 4.9 with a retic count of 0.2%. At that time, the bone marrow biopsy showed erythroid hypoplasia with normal cellularity, and there was no aberrant lymphocyte population with unremarkable cytogenetics. And his parvovirus PCR was unremarkable, and CT did not reveal any thymomas. At that time, the pure red cell aplasia diagnosis was made. He was treated initially with IVIG followed by the cyclosporin. He responded for 3 months, and he lost his response and became transfusion dependent. Following that, he got rituximab followed by danazol with no response, and then he was tried Cytoxan oral medication PO, but no response was obtained. So he was pretty heavily transfusion dependent and iron overloaded. So his iron chelation was started, but he had an allergic reaction to exjade and desferal. So because of this refractoriness, his repeat biopsy was done and cellularity was fine, but he had no erythroid precursors with no evidence of MDS and with normal cytogenetics. So he was treated with horse ATG and started the cyclosporin. He responded well for 6 years to the point that he was phlebotomized for his iron overload. But his pure red cell aplasia by February 2022 relapsed, and he was placed on cyclosporin. At that time, his biopsy was repeated. It showed less than 5% cellularity with unremarkable CBC with platelet count of 120 with white blood cell of 4 with an unremarkable ANC. And his bone marrow did show lack of erythroid elements, but there was a TP53 mutation with the variant allele frequency of 3.2%. So he was again given the horse ATG because of his first response, and he was started the cyclosporin. He continued to respond until December 2022, and then his pure red cell relapsed with reticulocytopenia. When at the time that he had this relapse, his iron overload was evident with his MRI elastography. And so his cyclosporin dose increased. He was started on EPO injections because of his CKD component, but he did not have any response. By April 2023, he started the sirolimus CellCept, but again, he did not respond to that agent neither. And then by June 2023, his creatinine went up to above 2, and he started the Cytoxan, and he will be getting the bone marrow biopsy. So his most recent bone marrow, this is the bone marrow that was obtained back in 2016. Again, a TP53 mutation with the 3.2% varying allele frequency. There was no PCR, PCR workup at that time. His most recent workup, this is from June, his reticulocytopenia is 2.2%, creatinine is 2.1, LFTs are normal. He does not have any autoimmune component. His hemoglobin is 6.5 with transfusion dependency with MCV of 84, otherwise unremarkable CBC.
So let me talk about a few really informative aspects of the case so far. One is that as it has become possible to do myeloid mutations, for example, with NGS panels or with more limited FISH panels, it is clear that there is a fair amount of myeloid mutations present in pure red cell aplasia. But as in any new area, particularly in new diagnostic areas, it's necessary to kind of figure out what the nuances and interpretations are. So a number of the studies that have been done have primarily found germline mutations. A number of the studies have shown primarily germline mutations, and most studies demonstrating myeloid mutations have been kind of like the present patient, where it is present at a worse than normal, but certainly not hugely high, sort of a CHIP, age-associated clonal hematopoiesis level, like this one. As the slide that was up here a moment ago was showing, about a quarter, little more than a quarter, well, a little less than a quarter of patients who have primary or idiopathic pure red cell aplasia, which is not obviously, since it's primary, is not associated with a known lymphoproliferative or autoimmune disease of other type, or a thymoma or anything like that, or parvovirus, of course. But a little more than a quarter, little less than a quarter of those have a myeloid mutation. Again, the typical sort of CHIP mutations, with TET2 being the most common. I would point out that TP53, the mutation here, is a decidedly unusual mutation in pure red cell aplasia as a potential myeloid thing. Almost half of patients who have been studied, and again, that's a caveat that that the patients who were studied have a thymoma, and looks like we're about to get back into the picture. Who had a thymoma, had a myeloid mutation, but as you would expect, a very small proportion of the patients who have large granular. Okay, back again. So as you see here, only a very small number of the large granular lymphocyte-associated pure red cell aplasia patients will have a myeloid mutation. So we can move on to the next slide. So there's a couple. I'll go ahead and address the comments, but one other comment on the original case is that the patient, has developed over time a chronic kidney disease type picture, and this is a complicating factor for the evaluation of pure red cell aplasia, because uncommonly, renal insufficiency, renal insufficiency sufficiently bad to be associated with anemia may be associated with erythroid hypoplasia, although not, typically at the absence of progenitor levels. But this has been recognized for a long time, and in fact, in the original classifications of pure red cell aplasia that came out in the 40s and 50s, the types were diamond black fan, which was congenital, thymoma, and renal failure, and then other, which was most of what we call pure red cell aplasia. So what's the mechanism of pure red cell aplasia that's not associated with large granular lymphocyte disease? Well, in pure red cell aplasia may be the morphologic manifestation of a myelodysplastic syndrome. And again, part of the hope for myeloid NGS and ability to look at myeloid mutations is to identify those patients who would be less likely, perhaps, this isn't even clear, to respond to immunosuppression, but, and to behave more like a myelodysplastic syndrome, because again, in many ways, the classic myelodysplastic syndrome, sort of pre-mutation myelodysplastic syndromes with pure red cell aplasia are just a morphologic variant of myelodysplastic syndrome. And nearly all the direct toxicity, drug-associated pure red cell aplasia, again, are direct toxicity. And of course, parvovirus directly infects the erythroid precursors through the P glycoprotein. But otherwise, the mechanism is immune dysregulation suppressing erythropoiesis. My old boss, Sandy Krantz, who passed away a few months ago, demonstrated in 1967 that a primary acquired pure red cell aplasia was typically associated with an IgG directed against erythropoiesis, and we'll give you some details on that. And when I was working in the lab with him, he had a freezer chock full of IgGs from various patients with pure red cell aplasia, and he was unfortunately using them for his true love in life, which was the erythropoietin receptor, and trying to find a pure red cell aplasia patient who had an antibody against the erythropoietin receptor so he could be the first to clone it, but that never panned out. In any event, so let's show you some classic pure red cell, in the next slides, some classic pure red cell aplasias, primary pure red cell aplasias associated with inhibitory antibodies. This is on autologous bone marrow from patients where we would purify, their doctor they'd be referred to us. We would purify the IgG fraction. When they come to see us, we'd do a bone marrow, and we would look at BFUE, and I'll show you why we looked at BFUE. And so you see patients who would have, relatively normal. Again, there's a huge amount of variation, and some of these patients, because of concomitant issues, would have lowish or normal BFUE, but they'd all have BFUE. When there would typically be a bit of suppression with a normal pooled IgG, which was basically IV IgG we got from the pharmacy at a standard concentration, but most would have a substantial reduction in their antibodies, in their BFUE colony formation when we added their own IgG. So these were IgG mediated effects. And if we could move on to the next slide. Again, you have to be set up to do this. So this is why this is an old study, and I haven't done these things for years. So this is other patients where from the same patients looking at BFUE, and these are again multiple patient results pooled here. As you see, the pre-treatment IgG knocks down the BFUE, and then when they're in remission, you get a decent response back up into the normal range, similar to with pooled IgG or with just medium only. You notice there's no particular effect on the CFUE, and there's less of an effect on the peripheral blood BFUE, which are less mature than bone marrow-derived BFUE. And then if we used CFUE, which we were able to generate from peripheral blood, which would be of varying purity, but a reasonably good modifier example of CFUE. We typically found that the antibody of the patient was directed against something that was presumably expressed in the late BFUE stage, and would not be present in on the CFUE. CFUE were assessed by culture results after about 7 days. BFUE culture results after 15 days, so they would have passed through the CFUE stage on the way there. So it's some kind of antigen. As best we could tell, it was some sort of antigen that was expressed in the late BFUE. Okay, we can move on to my next slide. So back to the case. What about benefit of looking for T cell clonality after unremarkable flow cytometry when you don't see any abnormal lymphocytes? So is it beneficial? Because it is something that it's my practice, at least, to recommend to people who reach out to me about their pure red cell aplasia patients. In terms of treatment, it might if you found a clonal T cell population, it might suggest that methotrexate, not generally a hugely effective drug in pure red cell aplasia, but its efficacy is in the kind of the LGL type pure red cell aplasia. It might predispose you to think about doing a trial of methotrexate, but it may help underlying pathogenesis and may lead to identifying mechanisms that may guide treatment. The general assumption is, and Dr. Boss, of course, is a major contributor to this understanding, is that the underlying defect in pure red cell aplasia is somewhere in the T cells, even though it may result in production of a specific antibody. There was at one point a report that said that T cells that had STAT3 mutations were less likely to respond to cyclosporin, but when that same group out of Japan looked at this in a subsequent larger study, they actually found no such abnormality. The majority of LGL-PRCA are, of course, going to have T cell clonality, but you're also going to see T cell clonality in a quarter to a third of thymoma pure red cell aplasia, and slightly less idiopathic primary pure red cell aplasia. So is it critical? As I said, I generally recommend it because, again, if I saw something and I wasn't getting a good response, then maybe I might think about something LGL type, like methotrexate. But that is the rationale for why I recommend it. Is there any value in doing a monoclonal gammopathy workup if you don't see anything suggestive of a myeloma population? Well, of course, IVIGG seems to work a little better in patients with monoclonal gammopathy, also with hypogammaglobulinemia. When would it be useful? It might be useful in a refractory case like this because there are some studies that suggest that plasma cell focused agents like bortezomib, which again would be more effective in kind of monoclonal gammopathy type things, or daratumumab, which is particularly effective in post-ABO incompatible transplant pure red cell aplasia, but again has been reported to be efficacious in more general pure red cell aplasia. Those might point you toward thinking about a trial. When should iron chelation be considered? Well, it was appropriately considered in this case because the patient was had gotten a lot of transfusion and was going to need, and at various points was going to need more. And it is a kind of a classic good response thing that at one point in his case, in this patient's case, the patient was able to respond, was able to tolerate therapeutic phlebotomy, which is, kind of a hallmark of a good response, because again, you need to get the iron out. There is some literature which suggests that iron chelation in and of itself, not just in pure red cell aplasia, but in other iron overload marrow failure disorders like myelodysplastic syndromes, is that iron chelation itself is associated with improved erythropoiesis. So, and we have, now, how long should one wait to evaluate the response to each immunosuppressive agent? So this is, I think, a potentially relevant question. And for the most part, the agents used in pure red cell aplasia, with one big exception, are generally going to show evidence of a response in 8 weeks to 3 months, typically 8 weeks or so. If you use a slightly higher doses of cyclosporin, which is what we used in our original studies when cyclosporin was a new idea, as opposed to being the standard of care, we would see responses faster, but we were using a dose that many of the patients really couldn't tolerate, and we had to go down, and we recommend a lower dose now. But the exception is sirolimus, which is really in my view, the up-and-coming drug in pure red cell aplasia, which seems to be slower in efficacy and to have its maximum peak somewhere around 6 months. So I am assisting a hematologist at another institution in a patient who is on a trial of sirolimus. And we are simultaneously tapering the not very well tolerated cyclosporin and prednisone they're on now while they're on sirolimus, because we expect that it will be 3 months at least before we start to see a response, and 6 months before the potential maximum response. So I think this patient was only on sirolimus for a couple of months before a transition, and it might have been helpful. It potentially could have been helpful to have waited a little bit longer. So how frequently next question, how frequently is horse antithymocyte globulin used in the treatment of pure red cell aplasia? And what is the typical response? Well, until cyclosporin, it was kind of, your frontline refractory therapy. Patients would typically get prednisone as a single agent, or some other steroid, but typically prednisone as a single agent up front. That would have a 40 to 50% response rate, but would be difficult to maintain at a sustainable dose. Now, some people might not require anything but prednisone, although that would be a decided minority. Pre-cyclosporin, those patients would go to azathioprine or cyclophosphamide, typically with steroids. But the next step before cyclosporin was to go to ATG. And typically, the most experience with ATG is with horse ATG. We used to have a study with rabbit ATG, which you can still get with some difficulty. Generally, what we found was that if the patients who got horse ATG could potentially respond to a second round of horse ATG, particularly if they had had a good response and relapse, like this patient. There was a moderate likelihood of response to rabbit ATG, and horse ATG could rescue refractory rabbit ATG patients, but rabbit could not rescue horse particularly well. But horse is what you got for the most part. It has a response rate around 50%, and this is an example of a very good response because they had a sustained response, but also they required some maintenance as most people will. But the response rate is 40 to 50%. And again, most people are going to require some kind of. So how do you explain the lack of response in refractory pure red cell aplasia? Again, assuming it's not, a primary, or there is something else going on, like, renal failure or something else. It's not unlike ITP or autoimmune hemolytic anemia or other. It is a question of finding the right immunosuppression or maintaining the immunosuppression for a longer period of time. So anyway, okay, so this is one of our cyclosporin success stories, and this is a patient who came to us from a hematologist elsewhere and was requiring transfusion every 2 weeks. Had a number of what was billed, had an IgG inhibitor, also had other autoimmune diseases. Let's move on to the next one. When you're looking at studies of immunosuppressive therapy, the complete response is easy to define. It is normal without transfusion. Partial response gets tricky because the agreed upon definition is a low but acceptable hemoglobin and hematocrit without transfusion. And one of the challenges when you are looking at studies, particularly studies that are from outside the United States and Europe, is that frequently levels of hemoglobin are considered acceptable that we would not consider acceptable in the US. For example, they might not transfuse until 6, or they might not transfuse until chest pain, regardless of what the hemoglobin is. So that's always a bit of a caveat in some of these studies. So let's move on to the next one. So right now, at this moment, and this could change, cyclosporin is the current drug of choice. Most studies, as I have said, done all over the place under all kinds of conditions, show somewhere in a 75, 76% response rate. The dose I recommend is 6 milligrams per kilogram per day. Once upon a time, I recommended higher doses, but they were not well tolerated, particularly by the elderly, with a standard sort of trough and obviously watching out. I try and taper people off, but I recognize, as the Japanese have clearly demonstrated in their studies, that most patients will require maintenance. So move on to the next slide, please. Sirolimus is the up-and-coming drug that I think has the prospect of knocking cyclosporin off the top of the heap. It has an efficacy in refractory cases in a number of small series, one of which is cited here, about 75%. Now, there is a study that has just come out in the last little bit in the Blood Cancer Journal, which was a trial comparing sirolimus and cyclosporin, which showed sirolimus to be superior. Slower response rate, but to have a superior response rate than cyclosporin. And my only comment about it would be is that this why do I think this is not enough to make you switch automatically? It is because the response rate to cyclosporin was only 60%, which is less than you would expect and that you would typically see in other studies. So again, sirolimus, peaks around 6 months, but certainly it is an agent worth your attention. Next slide, we'll look at some other agents. And it is likely that there is some patient who won't respond to everything else, but will respond to some immunosuppressive agent. And in many ways, your strategy for refractory pure red cell aplasia is to kind of ring the changes until you find something that works. Rituximab, again, in my review, I've never seen it work,
But that's because I don't see many cases of lymphoproliferative pure red cell aplasia. So it's been the biggest literature is there. It's very effective there. It may work in individual cases. Again, has a decent response rate overall. There have been studies of daratumumab, and it does seem to perhaps be the agent of choice in ABO incompatible stem cell transplant, pure red cell aplasia. Bortezomib is particularly useful in MGUS-associated pure red cell aplasia, maybe some role of daratumumab there. IVIGG for unassociated, for primary pure red cell aplasia seems to work better as, kind of in the selected refractory cases. This case is a little unusual in my experience because they had a good response to it up front, but it looks like they were also getting cyclosporin. So, hard to judge that out. Stem cell transplant, definitely, well, based on the reported experience, which is small, it is, seems to be a good drug. So let's move on to a little bit more of this case. Okay, so how would I do it? Again, if you want to start with single agent prednisone, that's not wrong. I don't recommend it, but I don't think it's wrong. My recommendation to start is prednisone and cyclosporin. My next line would be sirolimus. I would move cyclophosphamide or azathioprine, usually with prednisone, to behind sirolimus. This is the point at which, you kind of throw up your hands. IVIGG may be useful. Daratumumab may be useful. ATG which I have used a lot back in the day, is further back on my list only because it's difficult to use. And so that's my thought. Now, in this particular patient with an aplastic marrow, I would wonder about eltrombopag. There is some literature, small, that eltrombopag has some efficacy in pure red cell aplasia, and certainly it has efficacy in aplastic anemia. And we've talked about response times for agents. And the question of transplant, again, I talked a little bit about. It's been done. It seems to work. A lot of my pure red cell aplasia business is people reaching out to me from around the world and telling me about cases. And one the other day, doesn't seem to be responding to much of anything, has some kind of myelodysplastic features. And I, am thinking that that's a person where transplant might be a reasonable case. When do you consider discontinuing immunosuppressive therapy? I mean, obviously, if it's too toxic, this sort of thing. Is it ever appropriate to stop it? So, if you're going to stop it and they are not responding, then you're going to have to be in a support mode with transfusion and chelation. My objective is always to try and get people off immunosuppression, or at least to the lowest dose that they can tolerate. And as I mentioned earlier, the experience from Japan suggests that nearly everyone will need maintenance. Next case.
Okay, so we will go very brief on this. She is an 80-year-old female patient, African-American inheritance. It's first, back in 2010, she had diagnosis of thymoma. She had a partial resection. Again, in 2014, she had a recurrent thymoma in the area where she got another radiation treatment. She had lung metastases in 2016. At that time, started the chemotherapy, and her hemoglobin dropped to 3.6 with reticulocytopenia. She was started on octreotide for her metastatic thymoma, and then the bone marrow biopsy was done because of the reticulocytopenia. It was 5% cellularity with remarkable erythroid hypoplasia with unremarkable T cell clonality. So diagnosis of pure red cell aplasia was done, and she was started the prednisone and cyclosporin. She was transfusion independent for 5 years, and in 2021, again, she became transfusion dependent, where the biopsy was done, showed again the erythroid hypoplasia with overall low cellularity. She was started Cytoxan after the trial of tacrolimus, and she did not respond to tacrolimus or Cytoxan. And by May 2022, she was started iron chelation, and she was made to treat. She was given the treatment for her metastatic thymoma with etoposide, but she continued to require weekly transfusions. So this is a most recent bone marrow biopsy after May 2022. Cellularity was 30%, virtually absent erythropoiesis, no viral inclusions, and unremarkable NGS for MDS, and no aberrant lymphocytes. This is a most recent blood work with reticulocytopenia, unremarkable LFTs, and negative DAT. Hemoglobin still requires, she's still requiring transfusion with hemoglobin 3.5 with unremarkable CBC otherwise, and unremarkable MGUS workup.
So thymoma is in pure red cell aplasia is really interesting. Pure red cell aplasia was first described in 1922 by a physician named Kaz Nelson. He was actually interested in platelets, and what he thought was important was that there was some speculation at that time that megakaryocytes were a product of differentiation of erythroblasts. And so this was a patient who had good megakaryocytes but no erythroblasts, which is why he reported it. But in any event, a few years later, by 1928 and certainly in the early 1930s, there were a number of cases of the association of thymoma and pure red cell aplasia, and reports of responses with thymectomy. And so, like if you're taking an exam, thymectomy, thymoma, pure red cell aplasia equals thymectomy. Unfortunately, it also equals immunosuppression. Resection produces a response in about a third of patients. The responses are typically partial, and you are almost always going to require adjuvant immunosuppression, again, as the big studies out of Japan have demonstrated. And you could argue whether you should just do immunosuppression in these patients if they can't, and if they couldn't tolerate the thymectomy, that would be reasonable. But since the thymoma seems to be the driver, I think thymectomy should still be the first thing you do. Let's move on to the next one. So again, the issue is that thymomas contribute, which are associated with a variety of autoimmune phenomenon, hypogammaglobulinemia and the Good syndrome, myasthenia gravis, you name it. It leads to, in a mechanism that is not clear, certainly not clear to me, leads to loss of self-recognition and autoimmunity, and about a third of the cases are associated with T-cell clonality. But of course, T-cell clonality is fairly widespread in pure red cell aplasia, as we've discussed. Is it common to have a hypoplastic marrow? The answer is no. This raises the possibility of, is this more like a aplastic anemia thing, where the lesion is further back at the stem cell? It just happens to be manifesting itself a little bit more as pure red cell aplasia, because there are reports of aplastic anemia with thymoma also. It also makes you think, in this patient getting chemotherapy, of drug toxicity. How do I approach pure red cell aplasia associated with thymoma? I need to give you the caveat that it is more common in Asian populations than in non-Asian populations. And so I've only seen one or two thymomas. It's tricky to make the diagnosis because, kind of like this case, you can have the thymoma present first, you can resect it, and the pure red cell aplasia comes along later. You can have the pure red cell aplasia find the thymoma. You can have any combination thereof. Again, everybody, I believe, because the thymoma is the presumed driver of the autoimmunity,
that you should do a thymectomy, but virtually everyone is going to require, based on my reviewed literature, because again, I've only seen one, maybe two of these folks myself, they're going to need immunosuppression, because again, it's almost always going to be incomplete and not sustained. When should you switch it? Well, sirolimus, again, may not peak until about 6 months, but most other agents should be, 2 to 3 months, sometimes less. The agent best studied in post-thymectomy, in thymoma, pure red cell aplasia post-thymectomy, is cyclosporin, where again, there seems to be a good response rate. And this literature is mostly produced by the Japanese Pure Red Cell Aplasia Consortium. And the question of, as we talked about before, can you do transfusions with iron chelation instead of immunosuppression? And the answer is yes. But of course, then when you go down that path, that is the path to which you are committed. Obviously, you can add immunosuppression, unless you decide you're going to change your mind about immunosuppression. That is what you're going to wind up doing. If you are not going to do immunosuppression, or if immunosuppression is ineffective, that is what you're going to have to do. You don't really have a choice. Okay, I thank you all for sticking around. I thank you for inviting me to do this. I love to talk about pure red cell aplasia, and I commend you on what looks like a really fine program. And I'd be happy to, I have a few minutes to run over if necessary, and I'd be happy to try and answer any questions you may have.